These are going to be the key signs and symptoms to look for that have often been overlooked in our perimenopausal and menopausal population. These include symptoms of morning stiffness or joint pain, tendinopathy, which might show up in rotator cuff syndromes, gluteal pain syndromes, Achilles tendon syndromes, or plantar fasciitis. Patients might note reduced strength or slower recovery time after exercise, loss of overt muscle mass, muscle fatigue, cramps, or heaviness, soft tissue injuries that don't heal well, fluctuating pain that can worsen mid-cycle, especially when a patient's still in perimenopause and menstruating, new or worsened osteoarthritis pain, especially in the hands, knees, and hips, and a loss of physical confidence or an increased fall risk. Overall, we want to screen for pain, stiffness, declined healing time, and overall declines in strength. We want to use empathy as we're asking our patients about these individualized symptoms. These are physiologic, they're not psychosomatic. Now, we have a variety of musculoskeletal conditions that might flare or appear more prevalent during menopause and perimenopause. These are in 3 different categories. We have bone and structural conditions like osteopenia and osteoporosis, compression fractures, loss of height or actual kyphosis, curvation in the spine, sarcopenia, and osteoarthritis. In connective tissues, patients might notice an increase in tendinitis or tendinopathy. There's a higher incidence of frozen shoulder or adhesive capsulitis in menopause and perimenopause, an increased risk of plantar fasciitis and trigger finger or tenosynovitis. And then we have muscle and pain syndromes, including increase in myalgia and muscular fatigue, increase in restless leg or night cramps, increase of fibromyalgia flares, chronic back or neck pain, and a loss of recovery in post-exercise or a new onset of soreness with only light activity. Ultimately, the lived experience of these musculoskeletal changes in menopause can be quite varied. We want to focus on the descriptors as we work with patients, including questions like, are previously simple tasks now quite challenging? An example might be an inability to open a jar or an inability to lift an object. Is the patient's sleep impacted by pain? Are they having breakthrough pain at night? Are there new postural concerns? Are they noticing a hunching to their back or a stooped posture? And are they experiencing overall low power and low stability? This might show up at home, at work, or in the gym, and it's important to listen to your patient's language. Now, we also know that this syndrome shows up as symptoms, often clustered together. We want to look for symptomology in tendons, including new and lingering pain in our large and small joints, muscles, including soreness, fatigability, and cramps, also including delayed recovery. We want to ask about joints, specifically stiffness and aching. We want to think about fascia and connective tissue, including tightness or perceived reduced flexibility, and general health and healing. Are patients having a longer recovery time from strain or injury, or are they having balance impact, including feeling off center or feeling more unstable? These symptoms may begin years before final menses, specifically in that perimenopausal age range where hormones fluctuate so wildly. This can lead to a delayed recognition by both patients and providers. We want to start hunting for these symptoms early on. Now, how this has shown up clinically but has gotten missed for years really has to do with a misattribution to overuse or to a patient's mood. We want to look for clues that are patients utilizing high amounts of pain medication or multiple interventions without an accurate hormonal assessment. These can also be harder to spot with already active women. We want to look for patterns and other symptoms that are often just written off as stress-related or general aging. This could show up as a 40-something woman with frozen shoulder or plantar fasciitis with no trauma history. Maybe a 45-year-old runner with recurring gluteal tendinopathy or IT band pain. Women doing strength training or for the first time, maybe to manage their weight, but they have quick to injure type of scenarios. Women in their 50s with osteoarthritis flares that are placed on NSAIDs rather than a hormonal assessment, or an active woman with frequent cramps, myalgia, or fatigue that's just brushed off as normal parts of exercise. We want to stop, slow down, listen, and address these concerns. This slide really demonstrates our workup in brief. Now, the whole goal here is to not write off a patient's experience, but to work it up adequately. In this workup is also an assessment for hormonally associated symptoms from other body areas. We want to assess both for other causes and contributors for these pain and musculoskeletal considerations, and we also want to identify when hormonal decline is at the root cause. Some key labs outside of hormonal patterns include DHEAS, looking at vitamin D levels, magnesium levels, and really looking at a creatine kinase if we're suspecting an active myopathy that's outside of hormonal decline. Utilizing DEXA scans for body composition, specifically bone mineral density, using imaging when needed, specifically musculoskeletal ultrasound or MRI. We want to look at functional tests, including grip strength or short physical performance battery. And we also want to have key referrals in our back pocket, including physical therapy, sports medicine, rheumatology if we're considering an autoimmune condition. There are a number of screening questions for musculoskeletal hormonal connections. Now, if a patient says yes to over 2 of these, we want to consider that this is a global hormone-linked musculoskeletal condition, not an individual single symptom experience. These key questions include, did this injury occur without significant trauma? Did this pain or injury appear around the same time as cycle changes, hot flashes, or the onset of insomnia? Is overall healing slower than expected from prior injuries? Is there a pattern of multiple connective tissue complaints across different sites? Is this patient actually in the menopausal or perimenopausal age range with no prior injury history? And does the patient report ongoing symptoms of fatigue, brain fog, mood shifts, or weight gain alongside these musculoskeletal pain considerations? Our goal here is to be a good detective. We want to look for non-traumatic onset, multi-site pain syndromes, and slow healing. And then we want to correlate that with other symptoms like vasomotor or sleep symptoms. Ultimately, we're asking the hormonal why behind these musculoskeletal symptoms.
Start your 7-day free trial at KarazianInstitute.com if you're a licensed healthcare practitioner ready to evolve your functional medicine practice. Explore over 300 hours of clinical training, masterclasses with leading functional medicine clinicians, and certification pathways. Or check out the Academy of Functional Nutrition and Lifestyle Medicine at AFNLM.com. Whether you're on the path to certification as a functional nutritionist or simply want to optimize your own and your family's health, our skill-building approach builds real-world competence from the ground up. And lastly, if you're dealing with chronic health challenges, visit drknews.com for self-paced courses that help you understand and address fatigue, brain fog, autoimmune conditions, gut problems, and more using evidence-based approaches. The content on this podcast is for educational purposes only and is not intended to diagnose, treat, cure, or prevent any disease. Always consult with your healthcare provider before making any changes to your health regimen. Thanks for listening, and don't forget to subscribe and share with someone who might benefit.